Welcome to The Check-In, the Image podcast lifting the lid on women's health one honest conversation at a time. I'm your host, Ellie Balfe, and in each episode I sit down with some leading medical minds to explore the realities of our health across every decade. From hormones to heart health, this is your space to feel seen, heard and supported as you take control of your health span. Because when women are informed, we are unstoppable. Image The Check-In is empowered by Boots and sponsored by Samsung, Waterstone Clinic, Irish Life Health and It's for Women. Today I'm joined by Dr Shona Tormey, who is a consultant breast cancer surgeon at the University Hospital in Limerick. Shona, thank you for being here with us on The Check-In today. It's so great to have somebody with your experience and expertise with us. I believe you have co-authored a minimum of 16 papers on breast cancer research. Is that correct?
That's probably correct, yes. And I've collaborated with many trainees and with many institutes over the years. And more recently, I've been involved with the University of Limerick, who've been very helpful on the science end in relation to our local breast cancer research. It's always great to be involved in innovation and research, the end game of hoping to understand breast cancer and to progress patient care.
And tell me a little bit about your work as consultant breast surgeon.
So I've been a consultant for 16 years, as you said. It doesn't feel like that long. And I suppose every day is a new day. I say that when we go into work. And that's one of the joys of the job. I suppose my job involves looking after patients at its core. And I work as part of a team for patients who I meet for the first time in my clinic. They only begin to realise that actually there's a whole lot of other people involved in their care also. So that's everyone from junior trainees through the breast care nurse, through the consultant radiologist, the pathologist who they'll never meet, but that will have a very important input into patients from whom we've taken biopsies. And obviously for those who require cancer treatment, we have our medical oncologist, radiation oncologist, and then for patients on the other end of the treatment spectrum who may require input from the palliative care team.
I think that's very comforting, the fact that there's all these different touch points and a full team around a woman as she might be going through that. And breast cancer is the most common female cancer in Ireland currently.
It is, yes. So the NCRI, National Cancer Registry of Ireland, collates the data for cancer in Ireland, and as of 2024, we had an incidence of 1 in 7 women in Ireland will develop breast cancer in their lifetime. So that's an increase in incidence compared to, say, 10 years ago, where the incidence would have been perhaps 1 in 9. So that is believed to reflect two things. It may reflect increasing age of the population. We know cancer in general is commoner as we get older, and we do tend to see that reflected in the distribution or the age distribution of breast cancer. We are also seeing an impact from lifestyle factors, and increasingly there's a focus on trying to manage lifestyle factors to reduce breast cancer risk. So in terms of numbers, last year we had 3,700 breast cancers. Approximately 1,500 were diagnosed through screening, the remainder in the symptomatic service. For most of those women, they would have been engaged in a breast service in the country. So the breast services are distributed throughout Ireland. We have 8 centres and there are 4 screening centres. The Irish patients have ready access to breast care, and the pathways are well defined.
And coming back to the disease originally, so if we could go back to a very simplistic question.
Yeah.
What is breast cancer and what is it doing in the body?
Okay, well, I suppose a cancer is called after the organ in which it's discovered as the primary. So from that perspective, breast cancer is developing in the breast. There are a number of different tissue types in the breast, and we can break those down into a combination of connective tissue, fatty tissue, and then the functional part of the breast, which is the lobule and the duct of the breast tissue. So that's actually the gland. So breast cancer arises in the gland. There are two different areas that it potentially can arise in, and that gives rise to two potential different histological subtypes. The duct is where most breast cancers will arise, and some of you will have heard of invasive ductal cancer, but there's another subset called invasive lobular cancer, and again, that's a type that's becoming familiar to us in discussion in the amongst the breast communities. So a cancer cell is simply a cell that has lost its ability to regulate its own growth. So every cell, think of it as a building block, has the ability to turn on and turn off certain things that keeps it in the place where it's meant to be, doing the things it's meant to do. It also has a programmed cell death. In cancers, there are biological mechanisms that aren't working properly, and some of the things that should turn off or turn on don't turn off and don't turn on. And the end result is a cell that outgrows its place, and that can fail to die, and can start dividing by itself and growing in the site and invading the tissue. And the hallmark of cancer is invasion, as distinct from in situ disease, where the invasion hasn't yet occurred.
Explain invasion.
So invasion.
In situ.
So when I'm talking to patients, I describe it a little bit like curbing on a pathway. So if you were to consider the duct as a path with curbing on either side, normal uniform curbing that looks the same and goes in a straight line is the normal cell. The ductal carcinoma in situ cell will retain the uniformity and stay in the straight line, but it will look abnormal. It'll be bigger. It might stand out. It'll look abnormal in comparison to the surrounding curbstones. And then cancer is where that cell that block has actually multiplied and has invaded the grass. So you now have a block. You have curbing in the grass where it shouldn't be.
And the great risk then is, correct me if I'm wrong, but when it becomes metastatic and it moves beyond the breast. That's what we're trying to.
So the aim of diagnosing breast cancer is to ideally pick it up at a time point that it is early stage and where it's confined to the primary site, and where it hasn't metastasized, because that offers the best opportunity for treatment and disease control and beneficial long-term outcomes. Most breast cancer will be in that category. And for most women diagnosed with breast cancer, we are seeing very good long-term survival figures. And again, referencing the NCRI data, we have seen a huge improvement in long-term survival from 72% 10 years ago to 88%.
Wow.
In the past few years.
Tell me a little bit about ages. So what ages are you seeing? Is it typically over 50, or are people presenting now younger with breast cancers?
So I work in the symptomatic breast service. So in the symptomatic service, patients access the service through their GP. So we would tend to see the broad range of patients who present across all age groups. So we'll have patients referred from their late teens, early 20s, right through to their 90s. Obviously, not everyone referred will have breast cancer, and in fact, most patients won't have breast cancer. Do see an increase in incidence largely associated with age, and you can see that reflected in the statistics from breast cancer from last year, where we would see about 13% coming from the younger age group. That group would be the under 40s from 18 to 40. And then we're seeing from mid-40s to mid-60s, about 50% of our breast cancers are diagnosed in that population. So that largely spans the screening population. And then in the 65 to 75, we're seeing 18%, and over 80, it's another 18%, 19 and 18%.
Yeah.
So we see a peak in the middle. So increase in age, approaching the screening threshold, it begins to decline after our 60s. But we're still seeing approximately 20% of women will present in that age group with breast cancer. So it's still on the higher end of the spectrum compared to the younger age group.
Right, okay.
There is a move towards seeing younger breast cancer. That's also reflected in our data. It's a global trend. Some studies would report it to be approximately 2% per year, year-on-year increase. It's not clear why we're seeing an increase in breast cancer in the younger population, but it is believed to be due to lifestyle factors such as alcohol and weight gain. And we know there's a cohort of patients there who have genetic mutation or have an underlying family history that may put them at a higher risk. So a combination of those factors would tend to be reflected in the younger population.
Okay. Let's talk a bit about self-checks and screening and that whole space. So the screening system here in Ireland is from age 50. Is that correct?
That's right.
But going before that, in terms of self-checks, what would you advise women? When should they be checking? Should we be checking from teens?
So it's about being breast aware. Breast awareness is very important, and for women, and to be aware and empowered enough to be able to advocate for themselves in terms of accessing care. Doing a breast self-examination is very important. Now, breast self-examination has received some criticism over the years, but there are many groups that are helpful in terms of showing you how to do it correctly. Online tutorials, there's leaflets. The Irish Cancer Society, the Mary Keating Foundation, to name but a few, are all very helpful in terms of showing you what to do. In general, we recommend once a month, day 7 of your cycle, or the same time of the month if you're post-menopausal.
By day 7 of the cycle.
Yeah, so that's following your estrogen, progesterone phases of the normal menstrual cycle, and on day 7 of the cycle, your breasts, the breast effects of hormones on your breasts will mean that the breast itself is a little less lumpy and bumpy, and you're really more likely to get a true reflection of what's happening in your breast. So, regardless, if you're performing breast self-examination at the same time of the month, you're getting a sense of what your normal is, and that's really what it's about. What's normal for you? Is there something there that really sticks out as being abnormal? How do you examine yourself? We recommend looking at yourself in the mirror, checking yourself in the shower, lying down and palpating your breast. Think of it like a clock, going from 12 to 12, covering all quadrants and checking under your arms. A simple check once a month, just to ensure that you haven't noticed anything very abnormal. And if you have a concern, talk to your GP. Your GP will also examine you and then determine if you need to be referred in for a specialist assessment. And that's how patients can access the symptomatic breast units. So patients who come to the clinic will be seen by a clinician. They'll be seen by the breast surgeon who is in the clinic at the time, and they will also be clinically assessed. And for a number of patients, not every patient, but for a number of patients who have findings in their breast that merit more urgent imaging, they will have a mammogram, ultrasound and biopsy done on that day.
On that day?
On that day. So that is the standard of care in the breast units in Ireland. We aim to provide patients who have areas of palpable concern that they can feel, that we can feel, that we have a clinical concern about. We aim to have all of those imaged on the same day. And by and large, we're able to tell patients what we're looking at and what we will take a sample of tissue and they'll be brought back for that result. We can't give that result on the day, but we will be able to advise them that the findings are suspicious or the findings are benign. And that, I think, is very helpful for patients, so that they have a very clear picture as to what's happening. And obviously, most patients will be discharged. The vast majority will not need a biopsy, and there will be usually one or two patients who will have findings that require a biopsy and will need to come back to see us, and those patients may be identified to have breast cancer. And obviously that conversation is difficult for them. But by and large, I tend to find that if we've managed to detect and pick up the breast cancer, and we've discussed the findings with the patient, and we've advised them that their findings are suspicious, when we meet with them with the biopsy result, patients tend to be clued in to what's happening, and we're on the same page. We can discuss how we're going to treat this, what we're going to do.
How do you find a woman is in that moment?
I think the most difficult day is the day that they attend the clinic for the first time.
Yeah.
And that's true for every patient who comes in the door, regardless of whether they feel there's nothing really wrong, but their GP has sent them, so they're there. It's fine.
How much time will have passed? So if a woman finds a lump, attends the GP, what's the time frame between then?
So we see, any patient with a breast lump will be seen within 10 days, because they would constitute an urgent referral. So if the GP sends in the referrals, and most referrals are now sent in on HealthLink, we will see the patient within 10 working days.
Okay.
So patient will get a very soon appointment, a very early appointment.
And then when they're being given this news or having that conversation, are they with you?
They are.
You're
yes.
delivering this,
and the breast care nurse will be in attendance as well.
Yeah.
So it is distressing. I mean, some women will obviously be suspicious that that this is breast cancer, but it's still very difficult to have it confirmed, and there's a lot of shock. Patients are upset. We try to reassure them, spend time with them, and we make arrangements to meet within a timeline appropriate to the biopsy. There's a lot to take in.
Overload.
Yes, and a lot of patients are in shock, and they don't absorb a lot of information. But I find that when they come back for their pathology report, and we're in the space then for discussing treatment, they've got their head around it, and they're ready to talk about what we're doing, and where are we starting, and when are we starting. So it's the first day is difficult. The second day is easier, because we're now starting to talk about what we're going to do.
Yes. And then I guess it's about compassion and clear, correct information for the woman.
Yes. When we see patients back for results, their pathology and imaging will have been discussed through a multidisciplinary meeting. When I or my colleagues meet with them to discuss that information, we are giving a decision that is not just reached by us, but by the team. And we convey that information. Most treatment will start with either surgery or chemotherapy, depending on the tumour subtype. We discuss that. We give usually information about what that's going to look like for them. And obviously then, shared decision making is about what they're, if patients have the correct information, they can share in that decision making process, which is really important for progressing with appropriate care. So we spend a lot of time in discussing treatment options and the implications of the reports and the biopsy and the MDM discussion. So, and the breast care nurse will also go through all of that, and will spend time with the patient after I've gone through everything with them as well. So patients are given lots of time, and every question is answered, and they're offered opportunities for follow-up questions. They can call us. And they do. We can talk to them on the phone. If they feel they need a second consult, they're offered that. So, in short, really, it's about ensuring that the patient has all the information they require in
that's
order
wonderful to
to
hear.
make an
Yeah.
informed choice on their treatment options.
And they get a sense of the full treatment pathway, what you would advise that they
Yes.
undertake. This episode of Image the Check-In is empowered by Boots. Boots pharmacists are with you for life. They are often the very first stop when it comes to advice, care and guidance. For all facets of women's health at every age and every stage, Boots is here to help you feel informed, supported and empowered every step of the way. We are proud to partner with them to bring you the knowledge you need to future-proof your health. So in terms of screening and risk, Shona, what about genetic risk? Is it, do we need to be looking on both the maternal and paternal sides? What's the scenario there? What do we need to know?
So genetic risk, it can be inherited from either parent. It is still rare in terms of a cause for breast cancer, or a risk with breast cancer, I should say. It constitutes 5 to 10% of breast cancer cases, so 90% will not be genetic. But we are very aware of those who present to us with potentially a genetic history. So for example, younger patients with a triple negative breast cancer may suggest to us that this could be genetic. But the usual way we screen or look for patients to attend us is to have the GP refer patients in for family history screening. Many patients are very aware that family history constitutes a risk. They will often seek their GP's advice and the GP will usually refer to us. We have a family history service where a full family history is taken. The number of relatives are calculated, and then we assign or we do a risk stratification using a model, a standard model that's used in the UK. We use CanRisk, and once we've stratified patients into what we call a low, moderate or high risk, we can then assign an appropriate surveillance strategy.
What would that be?
So if we take low risk or population risk, those patients do not require enhanced screening and they can be reliably discharged back to their GP, meaning that they're discharged from the breast service, but we will always advise them to make sure if they have a concern that they come back so they can do that through their GP. The moderate risk group are those who have usually we're talking 17% lifetime risk, or 17 to 30%, I should say. So in that group, they should have annual mammography, and we start at 40 in our unit to 50. So annual mammography from 40 to 50. The high risk, those who have a 30% or greater lifetime risk, they're the group where we are trying to identify if there's a genetic mutation. And some families will have a known mutation. In some cases, we will pick up a mutation in somebody who has been diagnosed with a breast cancer but fits the criteria, and we will refer for gene testing. We don't offer gene testing in our unit, so we have to refer to either the National Centre for Medical Genetics, and the gene testing is done through that route. If someone is in a treatment pathway, that can be expedited, and that's important in terms of making decisions about treatment, such as surgery and prophylactic surgery or systemic treatment. But for someone who's asymptomatic and referred without a symptom and without cancer, we can refer someone with high risk or likely genetic risk for gene testing also. We offer surveillance to those patients also, and that can include an MRI. An MRI screening for the high risk or for the known genetic mutations will start from 30 onwards, so 30 to 49, and mammograms to 60. So a long time there for screening.
Yeah. But that will basically allow you to see what's happening, what's present in the breast.
So surveillance offers the opportunity, enhanced surveillance hopefully offers the opportunity for us to identify cancer at an early stage, and that's the aim of screening. But it doesn't prevent breast cancer. So what other strategies do we have available to us? One can consider chemoprevention, using tamoxifen, for example. And there's good data to suggest that we get a risk reduction in patients who take tamoxifen, and that's a reasonable, what I call middle ground in terms of risk reduction.
Okay.
Or then there are the patients who may benefit from prophylactic surgery. By and large, we tend to reserve that for patients who have a confirmed and known genetic mutation, because that's where we see the greatest impact in terms of outcome. And when we do risk reduction surgery, we're removing the breasts. It's usually for BRCA. We may be removing the ovaries. That offers the best effective way of preventing breast cancer. Get over 90% reduction in breast cancer. But obviously it's quite dramatic, and sometimes our patients are very young, so there's a little bit to provide, to be able to get to the point where patients are considering doing this, and we will involve clinical psychology at an early stage in terms of assessment. We will give patients information. We share the risks and benefits. We look at timing, important for oophorectomy for the premenopausal woman. We generally advise complete your family. Consider oophorectomy maybe at 39-40 after completing your family. So timing of surgery is important for that patient population as well. So all of those things are discussed through the clinic. Again, just to emphasize that these are the smaller group of patients that we have in terms of screening, but they do require more enhanced surveillance, and there's more complexity to the decision making around their care.
And I think there's still a lot around breast awareness that women don't fully understand. I mean, dense breasts as well. This is a big
minefield
area. That people are often told they may have dense breasts, but they don't know what that means.
Sure.
Can you just explain to us a little bit about?
Yeah, what are dense breasts?
Yeah.
Okay, so first and foremost, I will say my radiology colleagues will be much better at this, but I will attempt to go through breast density. So this has very much become a topic of conversation in the breast community. And what we talk about when we talk about breast density is the appearance of the breast on a mammogram. So when we do a mammogram, we see a black and white picture. Think about an X-ray. It's the same. It's the same type of image. We see grey, we see black, and we see white. So on a breast, the black and the slightly greyish area may represent fatty tissue. It's transparent. And then the glandular tissue that we've mentioned earlier, the functional part of the breast, is very white. So we have varying degrees of both of those tissue types in our breasts visible on a mammogram, and it's age dependent. So in our 20s, for example, we will have much more gland compared to fatty tissue.
Okay.
As we get older, the gland can shrink and we get more fatty tissue. And generally speaking, we accept that menopause and hormonal reduction and its impact on breast tissue means the gland should continue to shrink back. We see more fatty tissue, and mammograms become more sensitive after the menopause. Okay. So that's why standard screening would start from 50 and would encompass the post-menopausal or the perimenopausal woman, because if we've more fatty tissue, breast or mammography is more sensitive. The problem is that not everyone behaves in the same way, and the glandular tissue in our breast doesn't always shrink at the same rate. And sometimes there are reasons that it persists, and some women will have genetically predisposed, more fibrous, that's connective tissue, and glandular breast tissue. We see that on a mammogram as a lot of white tissue. The problem with having a lot of the white tissue on a mammogram is that it can hide a cancer. So mammograms are not as sensitive in very dense breasts, and there is a recognition that we may not pick up a cancer in a very dense breast. So that is one of the issues with breast density. And the other is that for reasons that are unknown or rather unclear, women who have very dense breasts do have a higher risk of breast cancer.
Okay.
So it is recognised to be a risk factor by itself.
How many women have dense breasts?
So up to 50% of women.
Oh, okay.
Yeah, in a screening population, will have dense breasts. In this area, there have been discussions about how to grade breast density. So if one accepts that there will always be some level of density in the breast, in other words, glandular tissue, then how do we go from a small amount to a large amount, and how do we define that on a mammogram, and what does it mean? Where we are in Ireland is that a request has been put forward to the National Advisory, the National Screening Advisory Committee, who have then approached HICWA in relation to just this issue on breast density. Okay. And then we will wait to hear as to whether we will then be reporting on breast density or not. The bigger question in relation to how do we screen those breasts still remains outstanding, and will be the subject of trials. And until we have large-scale clinical data to say that we have a better method for detecting breast cancer than standard mammography, even in dense breasts, we will be continuing to screen with normal mammography.
Mm-hmm. Okay, which is every 2 years.
Every 2 years.
50.
From 50.
Yeah. So you mentioned menopause and the change in our breasts at that age. We have to talk about HRT on the back of that.
Okay.
And I think since the 2002 WHO study, which everybody knows about now, it scared a generation of women off HRT for fear of breast cancer. But that seems to have swung around again when it was discredited. Tell us, what's the reality? What do you think?
Okay, so and straight up, I'll say really the best advice out there in relation to current practice and evidence base in relation to HRT is the British Menopause Society guidelines. So referencing back the WHI study, there was the Million Women study, and as you said, Ellie, those studies were all reported in the early 2000s, late 90s, early 2000s, and the end result was that everyone stopped HRT and nobody was being prescribed HRT. So the WHI study was updated. The long-term update results were in 2020. That, in conjunction with a number of other studies, has, as you said, discredited the findings and appropriately interrogated the so-called risk associated with the use of HRT. Really, what the take-home message from all of this is that HRT is being prescribed. It's being prescribed in slightly safer ways than it formerly was, and that the breast cancer risk associated with that is very small, and it's in the order of between 3 and 5 women per 1,000. And if
not zero.
It's not zero.
Yeah.
But the risk is perceived to be so small that the benefits that are gained from things like osteoporosis or cardiovascular risk and quality of life benefit far exceed any potential risk.
Yeah.
But as we've just said there, the risk is not zero. And in certain groups of women, there is a discussion required in relation to HRT use. And in general, specifically focusing in on breast cancer, we avoid prescribing HRT for women who have breast cancer, and we would generally be cautious in some subgroups of patients who have maybe abnormal pathology, but not breast cancer, but are on screening as a result. And in those patients who have high risk family history, we generally have a discussion. That there's no easy or answer to that particular patient cohort, but and there is data actually to say that they can be safely prescribed HRT, but in general we would advise caution.
And I imagine that is part of shared decision making.
Shared decision making with their
informing the woman.
Yes.
She's helping decide.
Yes, so it's all about shared decision making, having the evidence, weighing up, and like any medication, what are the benefits, what are the risks, what dose and for how long, and all of those things should be part of the conversation, and is part of the conversation with their healthcare provider. Specifically in relation to breast cancer risk, the risk is very small. Women can safely take HRT for a 5-year period. Thereafter, the risk increases. And obviously, if anyone has a symptom whilst they're on their HRT or otherwise, they should always seek their GP's assessment and be referred in for a breast assessment if there is a concern.
And I think for a little bit of clarity, I think in that study, in 2002, it was a different type of HRT than is being prescribed currently, isn't it?
Yeah, so the synthetic progesterones were recognised to be one of the bigger problems in relation to HRT prescribing and breast cancer risk, combined HRT, as opposed to estrogen-only HRT, just to make the differentiation between the two. It's combined HRT, which is associated with the increase in breast cancer risk. But as I said, the updated data and the newer studies have found that risk is much smaller than was originally thought, and far out and is far outweighed by the potential benefits for women.
Yeah. And if somebody does have a worry now, or they find something, can a woman just request a mammogram if they're under age 50?
So usually again through their GP.
Through the GP.
So I think we'll just touch on that for a minute, Ellie, because I think we spoke about it briefly before we started, and that's just the difference, the services in Ireland. We have a breast screening, which is a population-based screening initiative, whereby patients are invited to attend for a mammogram. The presumption is that these are well patients, and that there will be a low expectation of an abnormal finding. Obviously there will be, but in some cases, and that's the purpose of it. But patients can access this, they don't need a referral. Patients who have a concern, who are clinically either worried about their breast or their GP is worried about their breast, they will be referred, and they're referred through their GP. That's the symptomatic service. The symptomatic service in Ireland run from 8 clinics housed in, there are 4 in Dublin, that's Beaumont, St James's, and there's a symptomatic unit in Vincent's and in the Mater. And then we have Galway, Cork, Limerick and Waterford. So anyone who has a concern or a symptom or a breast worry, concern, problem, they would be referred through their GP for an assessment, and any imaging that is required will be requested then, usually through the clinician. The question you asked me is, how about a mammogram? So depending on the unit is the answer. If there is set up and capacity to offer direct access, as we say, mammography, there may be some available to GPs. Okay. But one of this was something that was changed when the units were put in place. So by and large, it's through the symptomatic clinic.
And what else should women be aware of? So when they're going to their GP, we know about looking for lumps, but just the other breast changes that we have to be aware of.
So a lump is the obvious one. The nipple turning in and staying in. Skin changes where the nipple, if it becomes eczematous or bleeds, a bloody nipple discharge, skin changes that mean the skin is tethered to something. So you may see that when you lift your arm, or you may see it as skin tethering over a mass or a lump on in your breast. A lump or a mass under your arm may indicate a lymph node. And one of the things that looking at the breast is if there's something very asymmetric. If you notice that the breast has changed, that there is a fullness or it looks different to the other side, Now there is some natural asymmetry, but if there's a very different appearance to this, that you hadn't previously noticed, that's something that we would like to see.
And what about pain? What about breast pain? Is that
So breast pain, we would generally perceive breast pain to be a benign symptom.
Okay.
And a patient who's referred with breast pain, if there are no palpable findings, will be triaged as a routine. From our perspective, that means they would not be seen within the 10-day window. They may be triaged into a 12-week window as routine unless there's a clinical finding. That said, we know that pain can be associated with we can find coincidental cancers that may have nothing to do with the pain. We can screen women and identify cancer, or lobular cancer subtypes may be associated with breast pain also. The key really is the palpable finding. If there's nothing to feel and there's no palpable area, by and large, we would have a low threshold of concern for those patients. Age plays a role as well. So cyclical nostalgia, pain associated with your periods, that can be normal, as opposed to a single area or a site that's persistently painful without any obvious reason. Those are two different types of breast pain. So just to clarify the type of pain. So normal pain associated with periods that resolves with the onset of menstruation, that can be perfectly normal, and it's usually not a concern. A pain that's persistent, that lasts outside of a cycle, that's located in one specific area, that may be slightly more concerning.
It's all about knowing what's normal, isn't it?
Yes.
For the individual.
Yes. It's all about understanding what's happening insofar as how do your breasts behave throughout the normal menstrual cycle in the premenopausal woman, understanding from looking at your breasts and examining yourself what your normal baseline is, and knowing to seek your GP's care if you've got a concern. So knowing and being reassured by the fact that you can have access to a breast unit if necessary within 10 days.
And I think women are so much more proactive now than maybe they used to be a few decades ago. Would you say that's
I'd say
right?
that's very, very true. And I think the knowledge around breast cancer and breast care services in Ireland has dramatically increased over the years. And I certainly would see more women accessing care, knowing that they need to access care, coming to the clinic and being knowledgeable about their care requirements, and it's great to see. So we're definitely seeing a patient generation that are empowered
and more informed.
Exactly.
Yeah, because I guess most women find their own breast cancer initially. Could you say that they're coming with a lump and a concern?
So I was just looking at data on this. So they say that probably only as little as 30 to 40% of breast cancer will be found on the basis of clinical assessment alone. Okay. So we, in the symptomatic service, patients who present with a breast lump, even for patients who present with a breast lump, we're still probably only going to find that about 20 to 30% of those will actually have a breast cancer, and the vast majority will be benign. And then we'll have a cohort of patients who've got routine findings, but will have an incidental, almost screen detected cancer on routine imaging. So, and then there are all variations in between. So from the perspective of women attending, the key is really to be breast aware. If you've got a symptom, get it checked out. Your GP, as I said, will refer, and the vast majority of women will require breast imaging. For those who don't have a finding in clinical assessment, the radiological assessment will complete that, and whilst we will largely detect over 90% of the breast cancers, 95% of the breast cancers through the symptomatic clinic attendance, there will be a small number that get picked up on the more routine screening also. So, but yeah, we the services that are provided are aimed at detecting breast cancer.
Finding them.
And yeah, exactly.
And tell me about the surgical journey for a woman.
Sure.
What's that like?
Difficult. So as I said, when women attend following their initial attendance and they're returning for results and a discussion on treatment, most women will start with surgery as their first intervention. So surgical options now are quite varied. But we're really talking about, do we need to do a lumpectomy, which means we take out the cancer, we leave the breast, or are we dealing with a mastectomy? And if we're doing a mastectomy, what reconstruction options are available to the patient, and are they available now, or do we wait until after treatment? So there's lots to talk about.
Yeah.
The other side of surgical management is what we do with the axilla. Very topical at the moment in breast cancer management. The axillary nodes, these are think of them as if you get a cough or a cold and your throat is swollen and you can feel what we call your lymph nodes enlarged. We have lymph nodes scattered throughout the body, and they are also present in our armpits. When we assess breast cancer, we assess the armpit to identify whether the lymph nodes there are involved in breast cancer or not. It's part of the staging of breast cancer. Allowing us to only remove 2 or 3 lymph nodes, we reduce something called lymphedema, which was the spongy swelling of the arm that can occur after surgery in the armpit. And it's caused by scarring and interruption of the lymphatic flow because the lymph nodes are removed. So we reduced it from up to 30% down to 3 to 7%. So dramatic reduction. And with that, then we see an improvement in shoulder function and quality of life for breast cancer patients. So standard surgery for breast cancer now includes a sentinel node biopsy. Okay. There are still patients who require an axillary clearance, and that is very much the subject of ongoing discussion and debate in relation to who needs an axillary clearance, but we discuss it as a consensus, as a multidisciplinary team.
Yeah.
So we discuss both elements of the cancer element of the surgery, and then we talk about the breast reconstruction. So lumpectomy, we may in fact require me to lift the breast, reduce the breast. Would
that be the most common, a lumpectomy?
Lumpectomy would be the standard of care. Yes. So we conserve where possible. The exceptions are if we have multifocal breast cancer, if we've got a very large breast cancer where it's involving most of the breast tissue. Yeah. If when I remove the cancer, there isn't sufficient breast tissue remaining to allow an acceptable breast conservation effort, then a mastectomy will be appropriate in that situation. Patients who have genetic risk, regardless of the size of tumour, may be offered mastectomy also. So, and that's generally a discussion in relation to timing. So that's risk reduction. So I usually will discuss the surgery with them. We'll discuss the timing of that. And we'll discuss reconstruction options for patients who need mastectomies. So by and large, we would. So you can patients can have either implant-based reconstruction, or what we call autologous or flat-based reconstruction, where tissue from elsewhere in their body is harvested and implanted in their chest wall. There's pros and cons to each approach. If the patient is going to require radiotherapy, we may choose flat-based reconstruction over implant-based reconstruction, or we may in fact delay the reconstruction until after the treatment. And that also has to form part of the discussion, because if we're using flat-based reconstruction, clearly it's a more complex surgery. There may be a longer recovery. There may be concerns in relation to side effects from the surgery, delaying the onset of oncological treatment, for example. So that's all part of the discussion with the patients. So some patients will opt to wait. Some patients will wish to have immediate reconstruction. Simplest form of reconstruction is implant reconstruction. Downside of the implant-based reconstruction is that implants don't last forever. And by and large, they require review and replacement at some time point in the future.
How soon?
Most implants are guaranteed for 5 years. In practice, they can stay for as long as they can stay there for much longer. But usually we will tend to see the implant get tighter over time. The shape changes. It's not your own tissue, so the feel is different. It becomes a less satisfactory reconstruction as time goes on. Benefits are that it allows you to preserve the skin envelope, which then enhances any reconstruction option down the line, usually. And it's not implants and radiotherapy don't go together. So radiation will cause a lot of distortion of the implant, and you can lose an implant with radiation. So we try to avoid implant-based reconstruction for patients who require radiotherapy.
Yeah, until maybe afterwards.
Yeah, until afterwards. Yes.
Gosh, I'm just imagining what a woman is going through.
Yes,
it's so complex.
It is complex, and there's no such thing as one size fits all.
Yeah.
Every patient is different. Every patient who is who has a diagnosis may bring other things and will bring other things, their personal circumstances, maybe their medical comorbidities, that also are important in that decision-making process.
Mm-hmm.
So it's about discussing the findings, discussing what would be ideal in terms of treatment, and what's possible from the patient's perspective, and then shared decision making. So I know that's the theme, but it is about reaching a point where we are both happy with where, well, most important the patient is, but we have a decision in relation to what surgery and when and timing.
So you have a plan.
Exactly.
And what psychological and emotional support is there for a woman?
So we're very fortunate, really, that we have. There's been such a lot of work in this space in the last few years, and it's such an important part of the breast cancer services in general. I suppose probably start with our breast care nurse is a core member of the multidisciplinary team, and really such an important person for the patient. And it's often the breast care nurse who first identifies that there's a need to maybe bring in some other specialty to help. And there are many options available to patients. So it from everything from counselling to cancer support services, which include things like cognitive behavioural therapy, mindfulness. Really important and beneficial can be the peer-to-peer groups. So whether there are on-site groups or whether there's like face-to-face or online, a lot of patients find these groups very helpful.
That's very
yes, and we get a lot of feedback from patients who have met fellow patients going through the same thing at the same time, and they find it very supportive, and they're able to discuss their concerns and their fears, and know that this is a shared experience, that they know what they're going through.
Yes.
And that seems to that I would certainly say seems to be one of the great things that patients are able to engage with. Sometimes there are counselling sessions with counsellors employed by the local cancer support centre, and that's where women can have a safe space to discuss things. We have social workers available where there may be concerns in relation to financial concerns, and what's available to women who have a diagnosis, because obviously they're going to need to take time out. There may be an impact on income. Social worker can be really helpful in terms of advising patients on what's available to them based on their personal circumstances. We also have psycho-oncology services available to us for women who may require extra help. Anxiety, depression, and fear are often symptoms, and stress are symptoms we see at the time of diagnosis, but often following a diagnosis as well for a period of time.
And I imagine the fear, even if they're through the treatment pathway, they're through surgery and into recovery. I imagine there's a fear of recurrence.
Yes, so there is
a roller coaster of
emotion. Yes, back? That's quite normal. But it is, and it's very. There's a time dependent component to it in terms of its intensity, and it's estimated that up to 50% or more patients will have a fear of recurrent event. That can decline over time, and is shown to decline over time, but sometimes there's a need to engage with some of our support services to help with the mindset around that fear.
And learning to thrive again.
Yes.
I imagine it's quite a mindset shift.
Yeah, it is a mindset.
It's now time to thrive.
Exactly. And reminding patients how and reminding yourself how strong you've been. You've survived your treatment. You've got through your breast cancer treatment, and it's about restoring that, belief and ability to return to life and return to normal activities or whatever is normal in
Do you find that
this
women
world.
report that they feel different? They feel
Yes.
immeasurably different from
Yes.
they were before.
We certainly see that, and some women will really struggle.
Yeah.
There's a sense of loss, and there may have been loss. Some women will lose relationships. They may separate from family. There may be, there may have been pre-existing concerns prior to the onset of a breast cancer diagnosis, but all of these things can change over time. And yeah, we have women who have it's almost a grieving process, and it's like loss, and it's difficult it can be difficult for them to move on into the mindset of survive and thrive, as you've mentioned. So we do try to identify patients who may be either at risk for that, or who are, we see back in clinic. They may not actually contact us, but we try to identify, have we a concern here? Is there a need to engage with, with more care here? So yeah, we try to support and give information to patients as to what's available to them, and try and advise.
And I wonder then, do you see on the opposite side of that women who feel immeasurably different, but to the positive?
Oh, absolutely.
Come through it. They've dealt with it.
Yeah, we do. But I think we do. And I think everyone who has come through it or gone through it will have been changed by it. And women can take their lives in a different direction as a result. And we've seen women go on to do incredible things, and build on the fact that they've had breast cancer, and it's incredible, really. But most women do incredibly well, and women are very resilient, and we see women returning to, the chief bottle washer, organizer, family member, carer, professional, career development, everything. And it's great to see.
It's great to see.
Yeah, it is really.
Well, it is.
Exactly.
So Shona, in terms of prevention and lifestyle changes or things to be mindful of for women, what would you advise to women in terms of lifestyle?
So there's a big focus on this at the moment, and in fact the NCCP have produced a lot of literature in relation to health promotion, and it's a very big part of, like, what can I do to reduce my risk, which is so important. The big ones for breast cancer are reducing weight, ideally BMI normal, certainly less than 30, and exercising. So we know that both of those things have a really big impact on breast cancer risk, and in some studies the combination of both is cited as up to 40%. Obesity is linked to enhanced estrogen production, so we get a lot of extra estrogen from fatty tissue, and that has been correlated with increased breast cancer risk. So reducing that will certainly risk reduces you, and there's data to confirm that. So that's a big one in today's world, is managing our weight.
And obesity is a BMI of 30? Is that
overweight is 25 to 30, and obesity, depending on the grade, but 30 upwards.
Right. Okay.
Yeah. Okay. So weight loss and exercise are big ones. Particularly important in the perimenopausal, post-menopausal woman, when estrogen, progesterone levels are changing. Weight gain can be a problem, but also the other side of that is that you can lose muscle mass. Sarcopenia has been loosely connected, sarcopenia being the loss of muscle mass, with breast cancer and breast cancer outcomes. So improving your muscle mass, looking at things like strength and conditioning is recommended. And exercise, including moderate and high intensity exercise through the week associated with that, will actually improve your outcome, or improve your risk profile. Alcohol is the other one.
Yes, alcohol.
Yeah, so alcohol was declared a carcinogen by the World Health Organization probably 10 years ago. And it is associated with an enhanced breast cancer risk, not just breast cancer, but other GI cancers and other cancers. Specifically in relation to breast cancer risk, even at low consumption, you still have an increased risk, often in the order of between 7 and 10% from a single unit per day. So even at low levels, you're enhancing risk. In general, the advice is to reduce or abstain if possible. And that will modify your risk profile also in terms of breast cancer prevention. So that's a big one, because we don't always take that one on board in terms of reducing risk. So those are the big ones, really. So alcohol and exercise and losing weight. The obvious ones, just general no smoking, stop smoking if you can. It's not specifically linked with breast cancer risk, but in general terms of your overall health. Engaging in a healthy diet, again, your general health, but eating healthily has also been linked to a better breast profile.
Okay. And how protective is breastfeeding, actually?
So breastfeeding actually has been confirmed or shown to improve or protect you from breast cancer. The mechanisms are largely unclear, but it would seem to reduce your risk of estrogen negative breast cancer, and that is directly related to the length of time for breastfeeding, and that's for more than a year. So for estrogen negative breast cancer, you'll reduce risk by breastfeeding for a year or longer.
Okay. Shona, what is your best advice to women for how they can advocate for themselves when it comes to breast cancer?
Yeah, being breast aware, knowing how to do a breast self-assessment, accessing care and not being afraid to access care through your GP, and patients should be very reassured that they have a very robust infrastructure supporting breast services here in Ireland, and all patients are able to access it. So for patients advocating for themselves, just be knowledgeable. There is plenty of information there on the internet, in watching television. A lot of patients are breast aware. There's a big focus on breast health. I suppose knowing what your normal is, being aware of what's not normal, and what that might look like. Knowledge is power. And don't be afraid to ask for help.
So the big takeaway: know you're normal.
Know you're normal.
And make the appointments.
Exactly.
And last of all, tell me what's giving you hope in terms of breast cancer treatment and innovation. Is it getting better? Is it going to continue getting better for women?
Oh, absolutely. As that improvement in overall survival figures that we're now seeing in Irish data is really reflecting what's been happening in not just in the treatment sphere, but in the access sphere, and that's really reassuring. But what's really positive is what's happening in the metastatic setting. So formerly metastatic breast cancer, a stage 4 disease, was perceived as a death sentence. And whilst it is still a diagnosis that carries concern, what we are seeing is that with newer treatments, we're seeing very extended treatment responses, with women living 10 years, 12 years, 15 years on treatment and still having a good quality of life. And that is such a change, and such a brilliant change to see in treating breast cancer. And there's very much a focus on in treating breast cancer in that setting and getting these very extended periods. The word chronic disease has been used, is used. It's not quite a chronic disease, but it has an implication for chronicity, and that's a very different approach to, say, 10 years ago, where we weren't looking at chronicity or many years on treatment. So it's very exciting. It's and it's very inspiring to see the differences a few years make in treatments.
So in summary, whilst numbers are increasing somewhat, treatment, innovation and care is also getting much better.
Yes, and we're seeing a reduction in mortality rates from breast cancer globally.
Yeah. Well, that's very inspiring, really.
Exactly.
Dr. Shona Tormey, thank you so much for your time today.
Thank you, Ellie. It's been very enjoyable, and thank you for your time.
Thanks for checking in with us. We hope today's episode gave you insight and clarity. If you enjoyed it, please like, subscribe, or share it with a woman you feel needs to hear it. Image the Check-In is empowered by Boots and sponsored by Samsung, Waterstone Clinic, Irish Life Health, and It's for Women. Thank you to our partners for making these conversations possible, and thank you for listening. For more expert advice and real women's health stories, visit the Image Women's Health Clinic on image.ie and follow us on Instagram. Until next time, take care.